ER-positive, HER2-negative breast cancer is a very heterogeneous disease. From our luminal A, which is more ER-driven with co-expression of the progesterone receptor, generally speaking more indolent in biology, and more simple genomes, such as PI3 kinase mutations. And then we have the luminal B biology, which is ER-positive, maybe a little bit less strongly so sometimes, PR-negative or PR-weakly positive, generally higher grade, higher Ki67, more highly proliferative, and the genomes are much more complex. Maybe have P53 mutations, which lends to a lot of cumulative mutations in the cancer, unstable genomes with amplicons in cyclin D1, FGFR1, MYC, loss of PTEN, so much more unstable. Those are much more complex cancers, not driven just by the estrogen receptor, but co-driven by a wide variety of other pathways, less endocrine therapy sensitive. So this is a big spectrum of disease, but in those two broad categories.
We now understand that ER-positive breast cancer is a group of different diseases with different prognoses and outcomes. And in advanced disease, we can have some patients who will have a prognosis measured in many years and live with their secondary breast cancer well controlled with different treatments, while others who ostensibly have the same ER-positive breast cancer can have a more aggressive subtype and their prognosis might be measured in 6 to 12 to 18 months. And we're understanding more about the different biological features that help us determine which subgroups those patients are.
Hormone receptor positive, HER2 negative metastatic breast cancer has a very wide spectrum of biology and natural history. The median survival from the time of diagnosis of metastatic ER-positive disease is in the 30-month range, on average 2.5 years. But of course, 50% will live shorter than that and 50% live longer. So how do we as clinicians, look at a newly diagnosed hormone receptor positive metastatic breast cancer? What kinds of things do we look at to kind of understand the prognosis of those patients and thereby, fashion the best treatment for the patients? The number one is disease-free interval. How long from the time of diagnosis to the development of metastatic disease did it take? The shorter, the worse. That's very aggressive biology. Time from the end of treatment to the development of metastatic disease is another. How long did that cancer go off of treatment before it took it to recur? Sites of metastasis, visceral versus non-visceral, particularly liver metastasis, brain metastasis. These are grave areas where patients' survival is foreshortened. The original grade of disease plays a role. Grade 3 disease versus grade 1, 2 disease. Again, the tempo of the disease and the kind of the propensity for metastagenicity. Is it just one or two organs of metastasis or multiple sites of metastasis? What about the strength of the estrogen receptor and the progesterone receptor? Are they both still intact? Do you still have evidence of strong signaling to the estrogen receptor, or is the progesterone receptor now gone? Suggesting that this cancer is not all about the estrogen receptor. Those are the main prognostic factors we look at, the grave clinical features that tells us this is a much more serious metastatic breast cancer and the patient's survival is likely to be foreshortened.